So, welcome everyone to our webinar, Infectious Disease Grand Round. Thanks to Dr. Dean Saleh. He's been organizing these meetings and keeping us together. I know everybody is busy and we try to join and learn from each other's experience. This group in particular has been very helpful to so many people. I mean, we get consults. That's for you, Dr. Rodriguez. Sometimes we reach out to each other, help, assistance with stuff. That's good. So we are joined today by Dr. Marcela Rodriguez. Thank you for joining us, and sorry about the technical difficulties. Dr. Rodriguez obtained her MD and MPH, and she's an associate professor at the Southern Illinois University, or SIU. School of Medicine. She did her fellowship in infectious disease at WashU, which is Washington University, at St. Louis, Missouri. And also, she did her residency in the same program as IU. She received her medical degree from the Columbia Library University. She has a special interest in antimicrobial stewardship. She did a lot of work assisting combating antimicrobial resistance in children. Dr. Rodriguez is also a board certified in infectious disease and also in PEDS. And she's a member of the American Academy of Pediatrics, American Pediatric Infectious Disease Society, and also the Infectious Society of America. Dr. Zadin Saleh, we all know him. He's the one leading this group, basically. He's our MVP. He's an associate professor of clinical pediatrics at the Southern Illinois University. He did his fellowship at the Pediatric Infectious Disease at Duke's and North Carolina, and also he completed his pediatric residency at Penn State. He earned his medical degree from the University of Khartoum in Sudan before joining the SIU now, where he's an associate professor. He practiced for several years also in Mayo Clinic Health System in Wisconsin. And at SIU, he worked on improving screening and follow-up care for infants exposed to hepatitis C, and actively contributed to pediatric antimicrobial stewardship. He's an active member of Pediatric Infectious Disease Society Global Health Committee. As the dean also shares the Antimicrobial Stewardship Working Group. He's board certified in infectious disease and pediatrics, and his long-term vision is to strengthen the academic and research networks in infectious disease in Sudan, and also to advance pediatric global health. Welcome, Dr. Saleh and Dr. Rodriguez. We are really delighted to have you here today, and we look forward great presentation, and also we can take questions at the end. Please keep yourself muted while they're talking, and I don't know if Saleh or Marcella would like to take questions during the talk or no, but we'll see how it goes. We started late; it's 12:20 now, so I'm anticipating 1 hour talk. So probably we'll go on beyond 1:20. Thank you all for joining, and special thank to Dr. Rodriguez for joining us today.
So I really appreciate for having me today, Dr. Saleh. Thank you for the invitation, and I'm happy to share some other of our cases. So case number 2 is a boy with headache and new onset seizure who was 10 years of age. So this is a 10-year-old male unimmunized since he was 2 years of age, who presented to the ED with new onset seizure-like activity. And he also reported 1 week of left-sided headache and 5 days of forehead swelling. So this was his first ED visit. He had a CT that I put the pictures there that showed pansinusitis, and they reported also some frontal region diffuse soft tissue swelling that's highlighted with the blue arrows. And patient in the ED was diagnosed with sinusitis, and he was sent home on oral azithromycin. So 2 days later, he came back to the ED for acute right lower extremity weakness. He was toxic appearing with fluctuant swelling of the midline frontal soft tissues and tenderness on the glabella and maxillary sinuses. He had a strength of 1 out of 5 on his right lower extremity. So he had a repeat CT that was this time remarkable for severe sinusitis, as it showed prior. This time with supraosseous abscess with possible intracranial left frontal subdural empyema and suspected underlying osteo. So he had a follow-up MRI of the brain and orbits that showed confirmed subdural empyema along the left cerebral convexity. You can see that in figures 1, 2, and 3. He underwent emergent craniotomy by neurosurgery, and he had evacuation of the subdural empyema, and he had endoscopic nasal surgery by ENT. So his intraoperative specimens cultures grew pan-sensitive microerophilic streptococcus and coagulase negative staph. And I just want to show there in the figure 2, we have pyogenic content like suggestive of subdural empyema and leptomeningeal enhancement on the right hand side. So he was initially started on broad spectrum antibiotics, including ceftriaxone, metronidazole, and vancomycin. And then later he was narrowed to ceftriaxone and metronidazole, and he completed 6 weeks. He had a repeat brain MRI at the end of therapy and showed remarkable improvement with no intracranial abnormalities or any residual extraaxial fluid collection. And he responded very well to therapy. He didn't have any more seizure activity and had resolution of the headache and gradual full recovery of his strength. So this patient had Potts-Puffy tumor, which is osteomyelitis of the frontal bone associated with supraosseous abscess. So a little bit of background about this entity. So this is a rare complication of frontal sinusitis. It is characterized by frontal supraosseous abscess with underlying frontal bone osteomyelitis. These entity can lead to life-threatening intracranial complications such as our patient, like meningitis, cerebritis, brain abscess, and cavernous or superior cellular sinus thrombosis. The incidence of intracranial involvement is uncertain, but is thought to be high. And prompt diagnosis and treatment of this condition is crucial for optimal outcomes. So just few key points. So Potts-Puffy tumor is relatively uncommon clinical disorder and most often presents in adolescents. We as clinicians, we need to have a high index of suspicion in patients who present with prolonged headache, frontal swelling, as well as fever, seizures, periorbital swelling, vomiting, altered mental status, or any focal deficits. Most common pathogens isolated in patients with Potts-Puffy tumor are strep species, staph species, and anaerobic microbes. So that's when we have to cover them empirically, we have to cover them broadly. Prompt surgical intervention is key, followed by extended duration of IV antibiotics, and usually should be between 6 to 8 weeks. And if we diagnose these quickly and accurately, most patients will recover without any residual neurological deficits like our patient. So just a little bit of our lit search. This is a case series published in 2023. These included patients during a 4-year period that presented with Potts-Puffy tumor. These were recruited in 2 tertiary centers in Israel, and they reported a total of 10 cases. Patients, the age range between 9 to 17 years, and most common presentation on these patients were headache, so 10 out of the 10 presented with headache, frontal swelling, 6 had that, and fever, 5. So I just want to highlight, as it is in the picture, that the most common organism was Streptococcus constellatus. Intracranial complications only happen in a lot of them, 70%. So I just want to highlight, the importance of early diagnosis and high index of suspicion for this entity. Okay, so moving on, or any questions about case number 2 or comments? Okay, so we'll move on to case number 3. This is a 3-week-old infant who was large for gestational age, who presented with cheek swelling. So this baby was born at 34 weeks and 5 days by normal spontaneous vaginal delivery to a mother who had all serologies negative. Pregnancy was complicated by diabetes, polyhydramnios, untreated GBS. Baby was hypoglycemic and received mixed oral and gavage feeds that included formula and express breast milk. Baby was initially on empiric antibiotics for rule out sepsis for 36 hours and Pangent. And then by 3 weeks of age, the baby developed suddenly a left cheek swelling, erythema, and warmth. Parotitis was suspected at that time, and that's when we got involved. So baby had, I would say, a pretty normal CBC with a white blood cell count of 10.9. Platelets were normal. CRP was increased at 3.4 milligram per deciliter. Baby had an ultrasound performed that revealed a parotid mass with some cystic areas that was about 1.7 by 2.1 by 1.7 centimeters. Baby required to be intubated just for apneic spells for 1 day. We got involved and we started the baby empirically on cefazolin, and then later on broadened to vancomycin and ampicillin. And then later on we transitioned to ampicillin sulbactam, and we added also acyclovir. We're just awaiting HSV workup. And then we knew that a mom was diagnosed with mastitis. So cultures were obtained. So from the baby, we obtained blood and CSF cultures that were all negative, and also CSF PCR was negative. We did on the baby a throat culture that revealed methicillin susceptible Staph aureus, and also mom's breast milk was cultured that revealed also methicillin susceptible Staph aureus with the same susceptibilities from the throat on the baby. Mom had other organisms in breast milk, such as like microphilic strep and cons. So we ended up treating the baby for a total of 2 weeks with IV cefazolin, with some transition to oral cephalexin towards the end, and baby had full recovery. So we diagnosed this baby with acute neonatal suppurative parotitis secondary to MSSA, and so we looked at the literature because this, I think, for us at least, was our first case. So we found out that parotitis is a rare condition in the neonatal period and is associated with marked swelling, erythema, and tenderness of the parotid gland. There are some key risk factors that actually our patient had. So prematurity is one of them. And why is that? Is because premature babies are at higher risk of dehydration. This leads to reduced salivary secretion and stasis in the salivary duct. And pathogens most commonly associated with neonatal parotitis are Staph aureus. This is the most frequent one. Other gram-positive, such as streptococci, coagulase negative staph, and then less common organisms are gram-negative, such as Klebsiella, Prevotella, or E. coli. So why the parotid? So we found that the parotid secretes only serous fluid. So this has non-bacteriostatic effect, and especially if there is ductal stasis. And transmission most of the time is through ascending spread via Stensen's duct or via hematogenous spread from a distant site. And we found very limited literature suggesting that infection may also stem from mastitis or infected maternal breast milk. From diagnosis and assessment of potential sources of infection, including maternal factors. And that's what I have. So any questions, comments about this baby? We don't have we assume this came from maternal breast milk because we found the same pathogen in breast milk and throat swab on the baby. So we just wanted to present this case because we think it was interesting. Questions, comments?
Hi there, it's Mustafa from Saudi. Could it be the other way around? I like it, the index is the baby and the mastitis is secondary infection.
That's a good thought. I don't know if this baby actually latched on mom. I think this was mainly express breast milk that it was given to the baby via gavage. That's a very good thought, but I don't think because the baby was premature, I don't think the baby was allowed to latch on, it was just express breast milk. So it's a good theory, but I think in this particular case, because baby was premature, likely it came like mom to baby rather than the other way. But yeah, that's a good point.
Yeah, good point, Mustafa. Actually, this observation actually comes a lot with herpes, neonatal herpes, HSV. A lot of time, babies they can be infected and then cause mastitis in the mother. That will show up later. But yeah, that's a good thought. But I agree with Dr. Rodriguez. I think this baby was never breastfed directly from the mother. All right. I'm gonna take on the next case. This is a case of a 3-year-old girl presented with fever, neck swelling, and tremors. So this girl, briefly healthy, was admitted after having persistent fevers. It started 2 weeks prior to admission with fever, vomiting, diarrhea. Initial presentation or initial symptoms, the fever, vomiting, diarrhea, was shared by other family members. All got better except her. She just continued to have persistent fever on and off. And when she come to the hospital, she also has decreased activity, not eating well, and had also some voice change. And taking more history after admission, and on examination, they noted also she's not moving her neck in full range, and also she had bilateral hand tremors. And on examination, she was tachycardic, had tender left anterior neck mass. Workup showed leukocytosis with 20,000 white cells. CRP was elevated to 19.7 milligram per deciliter, and SID rate was 107. Her thyroid panel also showed TSH was low, and free T4 was elevated at 2.7. Ultrasound of the neck was obtained and showed enlarged heterogeneous left thyroid lobe with hypoechoic areas. So we obtained a CT scan with the neck, which showed 6 by 3.6 by 3 centimeter multilocular wall enhancing collection, as you can see in the lateral and cross-sectional here, with some tracheal deviation, which you can appreciate more on these images. So the green star shows the trachea pushed to the right by the abscess, and here also you see the esophagus also compressed by the collection. So ENT and IR were consulted, and she actually ended up having fine needle biopsy and aspiration, which showed abscess with prevalent fluid. Culture eventually revealed Brevotella species and microaerophilic streptococcus. She was treated with IV ampicillin sulbactam for 2 weeks because of concern for oral intolerance was with oral antibiotics. So we decided to give IV for the whole duration, and she improved and her symptoms cleared with 2 weeks course. She also received propranolol for symptomatic hyperthyroidism with the tremors and tachycardia, and again improved and her thyroid function normalized by the end of antibiotic therapy. However, 2 months later, she went to the OR by ENT for evaluation and direct laryngoscopy, which revealed a sinus tract in the left piriform sinus, consistent with type 3/4 bronchial cleft anomaly, as you can see in the picture here. That's the classification. She ended up having left thyroid lobectomy and ablation of the bronchial cleft sinus. However, a month later, she had a recurrent abscess in the same area, requiring again incision and drainage by ENT, and at this time grew Echinella corrodens and microaerophilic streptococcus. This time she was treated with IV ampicillin sulbactam and switched to oral amoxicillin clavulanate and did well this time. So just a quick note about thyroid abscesses. They are rare due to thyroid being encapsulated and rich in blood supply and lymphatics, and also due to high iodine concentration with its antiseptic property. In children, thyroid abscesses are linked to branchial cleft anomalies, and usually on the left side, like our patient. And infection usually follow preceding URI symptoms, and commonly caused by Staph aureus, anaerobes, and the oropharyngeal flora. And management, you need prompt drainage of the abscess in addition to antibiotics, and also definitive surgery to repair any underlying anatomical problem. And monitor for complications, including airway compromise, fistula formation, thyroid gland destruction. Any question about this case before we move to the next one? Yeah, so this patient, we follow her for years after that, and no other recurrences since the surgery and the second recurrence.
Dr. Saleh, so did this patient have any swallowing difficulties since there was no compression of the esophagus?
No, nothing. No swallowing difficulty or airway actually compromised before the surgery. Yeah.
Okay.
This hyperthyroidism is due to the inflammatory process, like more blood coming to the thyroid, or what's going on here?
Yeah, I think it's just because of the inflammatory process, maybe hyperplasia because of the inflammation. But it's reported in multiple cases. Yeah, they can present with hyperthyroidism in addition to the thyroid abscess itself. Yeah.
Great, thank you.
Our next case is a neonate, again, 21-day-old boy, born at 37 weeks gestation. Birth history was unremarkable. Prenatal and postnatal history was fine until 3 weeks of age. He had fussiness and redness around his left knee. Just lasted in less than 24 hours. So the parents, when they noticed that, they brought him to the pediatrician right away. And in the office, he was having a fever of 101 rectally. So he was admitted directly to the hospital. And when he came in on exam, you can see there is erythema extending from the left hip all the way around the knee, and without flow shown. So very picture looking like a more of cellulitis picture. Workup showed white cell 3.7, platelets 178, CRP was increased to 6.4, and ESR was 8, and ALT was 8. So sepsis workup obtained, including blood culture, urine culture, lumbar puncture, with CSF studies, and we did respiratory PCR and herpes workup. It was started empirically on ampicillin, ceftazidime, vancomycin, and acyclovir. Investigation showed X-ray with our left knee was negative, and ultrasound showed superficial cellulitis, and MRI of the knee showed subcutaneous edema without collection, so consistent with, again, cellulitis. Brain MRI showed some ischemic changes and parenchymal hemorrhage, but CSF studies were remarkably abnormal. You can see with pleocytosis with white cells of more than 600, mainly neutrophilic with 67% and 15% bands, and glucose was 98, protein was elevated at 246. So eventually CSF culture grew Citrobacter causerii. Everything else was negative, including the HSV and respiratory PCR and blood culture. The baby was treated with meropenem and gentamicin. Gentamicin for synergy for the first week, and then continued with meropenem. The course complicated by seizures, and when we repeated MRI imaging again at 2 weeks of age, he developed large abscesses, as you can see here, required surgical evacuation. We finished the course of therapy with meropenem for 6 weeks just to make sure we don't have any inducible resistance, and um, um, baby, I think after that, no seizures noted, and in neonates, Citrobacter is known to cause predilection for brain abscesses. We don't know the exact pathogenesis of the brain abscess, but people think it's because of the vasculitis associated with the infection and the ischemia that leads to invasion of the bacteria and causing necrosis in that area. And actually, there is some studies in neonatal rats also showed the bacteria persist in macrophages, and thinking that's why it evades, clearance and cause abscesses. In our case, the unique thing about this case, it's presented initially with the cellulitis that prompted all this. There is a few cases reported of bone infection or joint infection or other focal infections, but not a lot of cases. Mainly brain abscess is the most common, and sometimes this brain abscess cases can be presented as sporadic cases, or sometimes even as epidemic cases in the neonatal ICU. So that's what's reported. Any question? So this patient actually,
can I ask?
Sure.
Just wanted to ask about the dual treatment with mero and gentamicin. Mm-hmm. Was there a particular concern? That's why you treated with two antibiotics, or is it just to be super cautious?
Yeah, just initially, I think we generally with neonatal gram-negative, we use gentamicin in the first days as a synergy until we know for sure the CSF is sterilized. So in this case, also we repeated CSF again after maybe 3 to 4 days later, and the culture at that time was negative. So that's when we stopped the gentamicin. But in the textbooks, most of them, they say they recommend empiric therapy for neonates with either meropenem or fluoroquinolones because of the possibility of the bacteria in the macrophages resistant for a while intracellularly. So some of people recommended Cipro, and some also recommend the gentamicin initially just to try to clear the bacteria.
Thank you.
Zadine, so this kid has the LB, just basically you want it to complete the sepsis workup, right?
Yeah, in the initial LP, yeah, just because with the fever, 2 weeks of age, came in with fever and the cellulitis. Usually, we know, like from our experience with group B strep, babies can present with late onset sepsis with focal infection initially, like they can present, say for example, with cervical lymphadenitis, but also associated with meningitis. That's why in babies in general, when they come like this, we do sepsis workup, including LP, because there can be disseminated infection from the initial local infection. Yeah.
Thank you.
Yeah, and unfortunately, I think this baby eventually ended up having some developmental delays and cortical blindness. He was admitted like 2 years later for an unrelated hospitalization, but yeah, he had sequelae from this infection. All right, we'll move to the next case with Dr. Rodriguez.
Okay, so our case number 6 is a 15-day-old who presented with fastness, porphyrin, and lethargy. So this baby presented with a 2-day history of fastness, lethargy, and not eating well. He was at X37 weaker, who was born to a 22-year-old mom, primigravida, via uneventful vaginal delivery. Rupture of membrane was more than 9 hours. All maternal serologies were negative, Mom was treated properly for chlamydia trachomatis infection. When the baby got admitted, the baby looked lethargic and had a low-grade fever, 100.8. Because of the age and the lethargy, poor feeding, he had a full septic workup that included a lumbar puncture, and his spinal fluid at presentation revealed significant pleocytosis with over 1,200 whites, with 68% neutrophils. Glucose was 3, extremely low, and protein was high up to 225. The gram stain, when they call us that night, revealed gram-positive bacilli, which we don't usually get this. And eventually, culture revealed Listeria monocytogenes, and then the multiplex PCR also revealed the same organism. On figure 1, we can see the patient's CSF culture that reveal small gray translucent colonies, suggesting of Listeria. So, baby had a brain MRI that showed dural enhancement along the supratentorial convexities and tentorium cerebelli, showed in figure number 2. The hospital course was complicated with hyponatremia and consists with SIADH. Baby got treated for 21 days of IV ampicillin, and in the first 7 days got gentamicin for synergy. Then baby went home, and 33 days after discharge, when baby was almost 2 months of age, he presented with upward gaze palsy and poor feeding, and he had repeat imaging that confirmed a diagnosis of hydrocephalus, and baby required BP shunt. So this is a baby that had neonatal listeriosis, meningitis. So listeriosis, we don't see this very frequently, even though in our textbooks they always list listeria as one of the pathogens for newborns, but we don't see this very often. So this is an uncommon cause of foodborne infection, self-limiting and immunocompetent, but can be fatal in neonates, pregnant, and women and elderly. Incidence worldwide can range from 1 to 10 cases per 1 million population, and manifestations can be severe, including bacteremia, neurolisteriosis, and maternal neonatal infections. So as far as maternal neonatal listeriosis, the average incidence of this entity is between 0.3 to 5 per 100,000 cases in North America. Listeriosis in pregnant women can lead to abortion, stillbirth, or preterm delivery. And usually pregnant women will present with unspecific obstetrical symptoms or influenza-like illness or intrapartum fever with symptoms subsiding by birth, and on occasions amniotic fluid can be stained brown. So listeriosis in the neonatal period, it is divided in early onset and late onset. So early onset is defined by babies who are 1 week or less of age. The presentations in the early onset neonatal listeriosis infection are mainly septicemia, pneumonia, and babies in general, they are associated, they're mostly premature babies, and moms would have chorioamnionitis, and we know that this transmission is transplacentally. Then after a week of age, we call this late onset neonatal listeriosis. This is less common. This is what our patient presented with, and usually happens in term neonates, and they're born to asymptomatic mothers. The most common presentation in the late onset neonatal listeriosis is meningitis, and the means of acquiring disease is not clear. So this is the biggest prospective study that looked at neonatal listeriosis that included 189 cases. In this study, 70% of the infants had early onset disease, 6% had late onset, 57% of the infants were preterm, and the most common presentations were lethargy, altered consciousness, fever, respiratory distress, rash, hemodynamic instability. All late onset cases, like our patient, presented with meningitis and bacteremia, and outcomes were severe for 9%, such as like patients with brain injury, and 3% died. Very important to know that antenatal maternal antimicrobial therapy is associated with reduced neonatal listeriosis severity. And this table just describes from this study, the mortality range. They found it 25% to be in early onset compared to 15% in late onset. Preterm, mostly in early onset disease patient population, and in late onset 20% only, and meningitis mostly in late onset like our patient. And just some local Illinois state data that we went back and looked in the last 10 years in Illinois. They've been reported 233 cases, 9% were neonatal cases, and 52% were in adults that were more than 65 years of age. So treatment of invasive disease for listeria. So it is recommended to give intravenous ampicillin or PENG in combination with an aminoglycoside initially for synergy. Carbapenems and trametrosulfamethoxazole are considered some other alternatives. For meningitis, it is recommended that we treat for 21 days, 3 weeks, and we should repeat lumbar puncture in 2 to 3 days to ensure the spinal fluid gets sterile. In our case, I forgot to mention in the first slide, so we repeated the spinal fluid, and we actually had some worsening pleocytosis. If this was on day 2, 3. Thank you, Dr. Saleh. So you see, it was 48 hours. We repeated. We had this time 2,000 whites compared to 1,000 at the beginning. Glucose had improved a little bit from 3 up to 11. We have more protein, but this time we didn't have any organisms or gram stain, and the culture did not grow. So this was reassuring. And so after this, we were able to stop the gentamicin. Of course, the multiplex PCR still showed the listeria. This was not surprising, but at least, the culture was negative, and that gave us some reassurance about stopping gentamicin. Okay, any questions about this case with neonatal listeriosis?
Dr. Rodriguez, when did you do the initial MRI, please?
This was done as soon as we got the first LP that showed significant pleocytosis, then we did the brain MRI.
Okay, thank you.
So every child that comes and has meningitis, we do brain imaging. Okay, so our case number 7 is a adolescent male who came with fever, fatigue, and a worsening acne. So this is a 15-year-old male, previously healthy, who came with 2-week history of low-grade daily fevers. The Tmax was 101.7, and he was feeling very tired. He reported also to have occasional rigors and chills and nose-wrenching sweats. He reported 20-pound weight loss over a 2-month period, which was significant. And then he mentioned that for the last month, he has had flare of his acne, mainly on the lesions of his back, neck, shoulder, and trunk. He was started on clindamycin by the primary care provider without significant improvement. And then he had occasionally mild headache, nausea, no vomiting, and he had some discomfort on touching the acne lesions. So these are some pictures of his rash, and as you can tell, significant acne, but presentation was pretty severe. So this patient was seen actually by dermatology, and patient ended up being diagnosed with an entity called acne fulminans, which we have never had before. So this is a rare skin disorder which presents with acute, painful, hemorrhagic clinical forms of acne. It has been reported, but there are not too many cases, less than 200 known cases, and mostly happens in male adolescents. There's several theories behind the etiology of this entity. One of them is elevated testosterone levels. Another one is autoimmune mediated condition or a genetic component. Things that are characteristic of the presentation. So usually there is a sudden onset. The acne is very inflammatory and ulcerated, mainly on chest and back, which is very painful. And then patients would have systemic involvement. So they would have fevers, weight loss, malaise, anorexia, joint pain. They have been reported sacroiliac joint, ankles, shoulders, and knee joint involvement, and they have hepatosplenomegaly. So treatment for these are corticosteroids and isoretinoin. And in this particular patient, patient was treated and got completely better, and resolution of the symptoms happened, I would say, in 48 hours. Any questions about this case?
I had a similar case recently with erythroderma, like very impressive erythroderma as well.
Okay.
Diagnosis was obtained on the biopsy, actually.
Okay. And you would expect this being so, inflammatory in nature, that they will need some antibiotics, but actually patients that get, like with acne fulminans, antibiotics don't work for these patients. So we as ID doctors, we tend to, well, this is very infectious, let's just try to give something, but no. This is just mainly like an inflammatory condition that gets treated with steroids and isoretinoin. So a good lesson for us. Okay, so this is another quick case. This is a sudden onset rash in a previously healthy 14-month-old. So this patient was actually admitted recently to our hospital. So 14-month-old, previously healthy, who came with 1-day history of a rash that was located mainly in the inner thigh area, groin, and some lesions on right foot and left hand. So there are the pictures. You see very significant in the thigh area, diaper area. A couple of lesions on the hands, and some lesions on the knee. So what is your diagnosis? Enterovirus, monkeypox, oropvirus, bullous impetigo, molluscum contagiosum. So who votes for monkeypox? Okay, one common enterovirus. Very good. He was not sick at all. He was not systemically ill, and actually his labs were super benign. He didn't even have a fever. Okay, 2 enterovirus. Okay, very good. Very good. So yes, in fact, so he had enterovirus. So the kid was admitted. We did some opening of the lesions, and we sent that for HSV, and we actually started the kid on empiric acyclovir, even though it didn't look very, suggestive of that, but we just started empirically, and then we also sent lesion enterovirus PCR, and this came back positive. The HSV was negative, so we were able to stop acyclovir, and he went home with supportive care. So this kid had hand-foot-mouth disease. So this is actually very common in our pediatric patient population. And kids with hand-foot-mouth disease, they have initially an enanthem that then is followed by an exanthem, and they usually would present with vesicles that erode to form ulcers on a red base. These are deep-seated, and they can be vesicular with gray-white color. They're oval or lancet shape. Patients would have them in palms and soles, and in younger children, you would have them in the buttock area, elbows, knees, perineum. Some patients would have something called bow lines that are transverse growths in the nail plate. And something that I think is fascinating is this onychomatosis. I don't know how to say that. It's basically nail shedding. They lose all their nails, and this occurs after a few weeks or months following hand-foot-mouth disease. So, can you move the next slide? Yes, so we all know what enterovirus causes and multiple presentations, but I want to highlight the ones that affect children and affect the skin area. So one very common is herpangina. This is mainly caused by Coxsackie virus, and these are patients that would come with they don't want to drink, they have a lot of drooling, and they have mainly lesions in the posterior palate. Then These, in contrast with HSV gingival stomatitis, patients would come with similar symptoms, but the lesions are mainly in the anterior part of the mouth, different than Coxsackie and Herpagnan, that is the posterior part of the mouth. Then the next one in the middle is hand, foot, mouth. As our patient, they would present with lesions in those areas. And then the other one, which sometimes we have seen, is eczema coxsackium. So these are babies who have atopic dermatitis or eczema as a baseline, and this gets infected with enterovirus and can mimic actually sometimes eczema herpeticum. Okay, any questions about this case?
There is a comment from Radian saying that they've seen multiple outbreaks in Saudi Arabia with some losing their nails. Yeah,
wow.
And similarly here in the US, usually every 2 years or so, we'll have an outbreak with severe cases. We've seen some cases with actually respiratory involvement, severe respiratory involvement requiring hospitalization for many children, but the skin manifestation also comes from time to time. I personally seen at least 2 patients also lose their nails, and it was very frightening for the parents, but usually they regrow their nails without any problems.
Can you add also for our colleague, like adult colleague, about enterovirus infection in newborn as well, please?
I'm sorry, can you repeat the question?
I was suggesting to add some information about like newborn infection with enterovirus, really.
Yes, thank you for bringing that up. Yes. So enterovirus is actually, it's a common virus that can infect newborns, and for the most of the time, babies, they can actually present with aseptic meningitis. So they come with fever, lethargy, sometimes even seizures. They have CSF pleocytosis, and some other kids would come with sepsis. Babies that are in like sepsis, multi-organ failure, hepatitis, and they have basically enterovirus. A lot of our neonatal rule out sepsis if they have enterovirus, but they're clinically stable. We actually, after 24, 48 hours of negative culture, we send them home with supportive care. Finding enterovirus in a newborn, like in the spinal fluid, I mean, we feel a little bit more reassured that it was not bacterial meningitis, but yes, we can have babies that can be severely ill with sepsis and multi-organ failure secondary to enterovirus.
I came across a case while in the UK, but early neonatal enterovirus, not only with encephalitis, that's why he was diagnosed, but also developed myocarditis with some chronic heart failure and pancreatitis, needing some transiently at least insulin, which was very fascinating.
Yes, we have had kids that come with pericarditis, myocarditis, cardiac failure secondary to enterovirus infection.
Thank you.
You're welcome.
There is a question about, do you know the strain common in your part of the world?
For hand, foot, mouth disease, it's mainly Coxsackie A6. For disseminated infection or neonatal infection, I have to go back and look. Do you remember, Dr. Saleh?
Not in my hand, but it's definitely tracked annually, and there is like ED 68 cases with CNS involvement. But there is definitely the CDC track the whatever strains every year. Yeah. All right, we'll move to the next case, and this is a case of preterm presented with a skin lesion. So this is a female preterm baby born 28 weeks and 4 days to vaginal delivery to a 28-year-old mother. Pregnancy complicated by premature rupture of membranes at 27 weeks and 6 days. So 5 days, the membranes rupture for 5 days, and mother received antibiotics. And After the baby was born, he was in the neonatal ICU for prematurity and receiving supportive oxygen and otherwise stable. Initially, they did sepsis workup at 24 hours, and cultures were negative at 36 hours and was stopped antibiotic. But on day 3 of life, the baby had developed a white pustule with an erythematous base on the left posterior flank. So they suspected, pustular infection with skin infection, and then blood culture was obtained, and baby was started on empiric antibiotic, I believe ampicillin, ceftazidime, and vancomycin while waiting culture results. And also they used topical bacitracin ointment. So on day 7, 4 days later, the baby developed many vesicles in band-like distribution on the left side area, as you can see in the 2 photos. So this prompted skin lesion to be sent for PCR for VZV and herpes, and they started acyclovir and also did workup for HSV. So baby had PCR from the blood, from the skin lesion, and surface swab. And the surface, the PCR came back positive for HSV2 in the blood and the skin lesion, and also the surface swab. There was no evidence of disseminated infection in the CNS. CSF was unremarkable, with PCR was negative. And there was no other organ involvement. X-ray was negative for pneumonia, and liver enzymes were normal without suspicion for liver or hepatic involvement. This infant completed acyclovir for 3 weeks. We elected to do 3 weeks just because of the severity of the course and the baby's prematurity, but you can argue you could have done only 2 weeks, given no CNS disease or disseminated infection. After discharge, baby was started on long-term oral acyclovir. Usually you do this for at least 6 months to a year sometimes. We also looked at similar cases with neonates presenting with zoosteriform-like eruption from herpes, and there is 6 similar cases, mainly in premature babies. Only 2 were term, and they presented with blisters and sometimes with denuded skin and multiple lesions. And HSV2 was the most common, but one case was HSV1. And most of these cases, again, treated with IV cyclovir, and on outcome, some of them, they have recurrences. Our patient actually has 2 recurrences until she was 1 year of age. The mother actually did not have any genital lesions or even known history of previous HSV infections. And this is very common actually in about maybe 70 to 80% of the time. There is no documented or known maternal history. HSV can be potentially devastating disease with high morbidity and mortality for babies, and can be acquired in utero in 3 to 5% of the time. Perinatally is the most common, and 85%, and postnatally reported in about 10%. We usually classify HSV in neonates into skin, eyes, and mouth disease, SEM, or CNS disease or disseminated disease, which can present with sepsis picture or coagulopathy, DIC, or this organ involvement like pneumonitis or hepatitis. SEM, skin, eye, and mouth disease, comprise about nearly half of the cases, and usually present between 1 first week and second week of life, similarly to the disseminated disease. And CNS disease usually present later, between 2 to 3 weeks of life. So take away from this case, neonatal HSV can uncommonly present with zoster That's very rare, but and in our case, we think likely the transmission occurred early on because baby was ruptured, membranes were ruptured for 5 days before delivery. So the first skin lesion presented at day 8 of life, if you can say, and less than half of the neonates with proven disease can present with a characteristic vesicular lesion. So sometimes it's challenging to diagnose HSV if you don't have the characteristic lesions at presentation, and that's why we include HSV workup and almost all the newborn babies, especially in the first few weeks of life. PCR helps a lot in confirming diagnosis and differentiating it from VZV and other viruses. And also, it's important to know that if even skin, eye, mucous membrane, neonatal HSV, it's important to admit babies and treat with IV acyclovir promptly, because if you don't, then you risk progression to CNS disease or disseminated disease, which can occur in 80% of untreated SAM disease. I think that's the end of our last case, and thank you for attending, and any questions?
Dr. Saleh, there was a question in the chat about when was a cyclovir started on this baby, and when was the CSF done?
Yeah,
how many days into illness?
So they on day 7. Yeah, so the baby in the first lesion was noted on day 3 of life, and then on day 7 when he had the disseminated rash. Initially, their thought was, could this be varicella? So they did send the skin lesion for varicella and for herpes, and that came back positive quickly as HSV1. So we got involved on the same day. Actually, the PCR was sent on the same day. We got the result on the same day, and he was started right away on day 7 with IV cyclovir. And after we did all the workup, but the CSF came done on the same day.
So actually, my question was relating to the fact that if you have a CNS HSV, within the first 3 days, you might not have any shedding in the CNS or in the CSF, to be exact, and therefore you have to kind of repeat it after the first 3 days to see if you have a dissemination. I don't know if this, I mean, it used to be that, at least what I remember, the case, and it is our practice here, but I wasn't sure if that's the situation with this particular baby, and that's why I asked. And if you do it after 10 days of acyclovir, you lose catching the shedding, and so you kind of can't tell for sure if there was a CNS involvement or not.
Yeah, I agree with you. Sometimes we do the same. If we have a baby, we're suspecting, this could be CNS HSV disease, and the first initial LB done, like say on day 1 of presentation, we usually repeat it again, but you have to do it before 5 days of IV cyclovir. I think there is reported literature that once you start IV cyclovir, the PCR from CSF can take up to 5 days to clear. So after 5 days of on IV cyclovir, if you repeated the LP, you might not find it. But in this case, we didn't repeat the LP again because clinically was doing okay, no CNS concern. But we eventually did also 3 weeks just to be on the safe side. So we end up doing 3 weeks either way.
Yeah, and the other thing I wanted to kind of comment just quickly, I'll finish. The with these cases, because one case that I saw as a resident actually, so it just tells you how infrequent it is. I was in Canada. It is anyways to see in this age. But that particular kid we thought the risk was related to oral shedding, and mom and dad, they had like that kind of reactivation from stress when they get it, and so just by the kissing and that sort of thing. And the lesion was in the scalp, hidden below the hair, so it got missed by the pediatrician in the referral hospital. We started recyclable as part of the sick baby kind of protocol, and that kid unfortunately progressed to disseminated disease. But it was a single lesion hidden in the hair on the scalp, so it's really kind of scary sometimes, really.
Yeah, so that's why important when you have a baby, with sepsis workup, usually we look at, the scalp. You also, if a baby is circumcised, you have to look at, the circumcision site. You look at the umbilicus. Anything like this, even with a single lesion, that can be important. Yeah.
Greeting for everybody. Yes. Usually we get consultation frequently for the same scenario. Either the mother has history of herpes infection, or the opposite. The mother is symptomatic and the baby had spheric lesion. So my question: can we have a low threshold to start acyclovir as early as possible with this outcome and devastating disease?
Yeah, I mean, if you have a neonate presenting, in the first, say, 4 to 6 weeks of life, HSV has the same incidence like serious bacterial infections in babies. So that's why we tend to do workup and have low threshold to do workup with all babies with suspected sepsis. But the problem is with if the mother has if there is family history of say skin lesions or cold sores, fever blisters, then definitely you'll do your workup. But HSV is very common and ubiquitous, so a lot of time, most of the time when babies have infection, the parents or the mother can have asymptomatic shedding or without even showing the symptoms. So it's difficult to just base it on the clinical presentation of the parents. So you should just do workup for everyone.
Dean, I have a comment and question.
Sure.
So thank you so much both for the presentation. This is like a really wide range of infections, and it was very fascinating seeing these pediatric cases. So my comment is, I just recently saw a case with HSV encephalitis, like meningitis. I just want to mention this because I think it's particularly important. So patient after they get the HSV encephalitis, there is an autoimmune encephalitis that can follow, and this is called NAMDA encephalitis. So I just saw a case. So the adult, when they develop the NAMDA encephalitis, they get mostly psychiatric symptoms. So they can manifest with psychiatric manifestation, but the peds, they present with movement disorders. I don't know if you guys see this or no, but I just had a case like a month ago. It was like long thing, ICU stay, but apparently he had HSV encephalitis, meningitis, and after 3 months or 4 months developed psychiatric manifestation, and this was all proven autoimmune encephalitis, and it's like the NAMDA antibodies were positive from the CSF. My question to Dr. Rodriguez is, regarding the case of listeria, I couldn't ask this question when you were presenting. I've seen a listeria case like a year ago. It was really bad. The patient ended up dying. So I don't do well with listeria meningitis. But my question, and then he got rhomboencephalitis, brainstem involvement, all complications. So my question to you is, I read some, so we always give steroids when we treat meningitis, but there is decent literature that recommend against using steroids if you're treating listeria meningitis. Do you have a comment on that? And I don't know if your patient got steroids or not.
Yeah, thank you for your question. For listeria in particularly, we didn't find any literature supporting steroid treatment. In pediatrics, there are very few entities when we use steroid for meningitis. One is for H flu. For sure, we give steroids. Usually should be before we start actually antibiotic treatment or very early on in the course. And the other one, but that's questionable in the literature, is strep pneumo. But for listeria, we didn't find any evidence about giving steroids, at least in the pediatric population, is beneficial. And our patient did not get that.
Yeah, thank you. Because if it's listeria, you should not give steroids. That was my point. I mean,
Yeah.
we always give steroids in adult before the antibiotic, and it just like associated with bad outcome.
And for your question, Khalid, about the NMDA, yeah, we see this in older children, adolescents, and older children, but not in neonates, as to my knowledge.
Going back to the case of Citrobacter causeri brain abscess. As we know, this is intracellular organism, and you said it survives in macrophage, and it's also hard to be eradicated, and it has high mortality outcome. We have actually same scenario or same case. Maybe 1 year back, it was neonate with Citrobacter brain abscess. So we treat the patient with meropenem for 1 month, and despite that, the patient remains symptomatic with increasing abscess. He needs intervention, and by intervention, the culture of the abscess grows Citrobacter at that time after 1 month of treatment. So my question, what is the role of combined antibiotic in such a scenario?
Yeah, I think that's why some textbook they suggested using either combination or even fluoroquinolone just to have intracellular component. And actually, one of the textbook they mentioned that there was a patient, a neonate, had infection with meningitis and treated, and 4 years later, this infant, after the meningitis resolved and everything, but 4 years later underwent neurosurgical procedure, and the CSF is still at that time also grows Citrobacter. So it definitely you can have chronic, I guess, colonization or resistance after treatment, and that's why maybe combination therapy or adding fluoroquinolone may help with the intracellular component. But it's something rare. I don't think we'll ever have
very rare, yes,
a study to prove this. But I think just from clinical,
if you went through the literature, it will be very rare. No much cases are there. Another comment, Azuddin, in the patient with MSSA parotitis, you step down to the oral antibiotic in neonate. Again, what is the pharmacokinetics, bioavailability in such? I think this is considered a severe infection or a neonate.
Yes, thank you. So in our patient, so this baby was not bacteremic, had some inflammatory markers, and we initially did IV antibiotics, but later on we transitioned to oral because baby was doing well. So if we're suspecting, of course, if we have bacteremia, meningitis, we have to do the whole course IV. But or if they are actually in the NICU, we complete most of the time IV. But I think this baby was doing well. I don't remember this case in particularly, but I think after a few days we transitioned to oral, maybe loss of IV access. That sometimes can be an issue in our NICU. But disseminated infections, yes, we do always IV. For this particular one, I think we transitioned at some point because it was safe to do that. But I have to tell you that finding actually a dose of oral cephalex in the newborns has been challenging. So sometimes we have to call the pharmacist for suggestions, because if you look in the neofax or any neonatal pharmacology book, it is not listed. So I'm guessing the pharmacodynamics and pharmacokinetics can be a little bit hazy in this patient population.
Thank you.
Yusra here from Riyadh. Thank you very much. Really interesting and hugely educational cases. So yeah, children are indeed not just young
or little adults. And your collection of cases today succinctly demonstrated that. So if we kind of exclude your congenital syphilis case, which by definition cannot occur in an adult, and the listeria SAT case, almost all the other cases have no direct equivalent in adults. So we've learned a lot today. The Popfy tumor. I'm very pleased to learn about this because we're forced here to look after adolescents and people who are 14 and 15. So I wouldn't have known that a lot. You have presented that case about the suppurative parotitis, and that is, Mustafa's theory about the other way around. I think you're right. Maybe the proximity to the mother's breast is probably the root. However, it's always been a question for virologists why parotid gland is disproportionately affected by paramyxoviruses, respiratory, like mumps is known, but also parainfluenzas. So maybe the exorine juice being devoid of immune cells, just being serum, is a very good theory. And the same thing go for your other interesting case of thyroid abscesses and why we don't see a lot of thyroid abscesses. I haven't seen any thyroid abscesses actually. Until recently there was some mass, and one of our more experienced ID physicians here said to me, "This is brucella." And I was like, well, what are you talking about? I haven't seen an abscess of brucella anywhere, let alone in the thyroid gland. But he did the testing, and it was actually brucella. So there are a few things that we're still doing. So well done for doing that lumbar puncture in the patient who progressed and became an abscess, brain abscess, because that again demonstrates the importance of CSF analysis in sepsis in children. But we don't do that in adult much. One last point about losing nails in the enterovirus case. You remember last year we presented a case of a lady who's a Wegener's granulomatosis, who's been on rituximab, thereby she was having hypogammaglobulinemia, and then she presented with diffuse enteroviral infection, which was a Coxsackie A6, and she lost her nails, and we were like completely mystified because we don't see that in adults much, not these days anyway. And later on, unfortunately, she had an infection during her pregnancy, and she had a damaged baby with the same organism, with the same Coxsackie A6 patient. One last comment that is very close to my interest is the zostriform herpes simplex case. That's very interesting. Of course, these days things are easier because you've got a herpes simplex or a VZV PCR that can sort things. However, the zostriform rashes of herpes simplex, even in adults, and normally it's acquired in childhood, people will say, "I've got recurrent zoster," but the fact that they are recurrent is the main feature that will make a physician, or should make a physician, differentiate between HSV and VZV. Once you say this has happened 3 times, 4 times, you can be almost sure this is not VZ. This is a zostriform herpes simplex rather than VZ. So thank you so much for very educational and very entertaining as well cases. Thank you.
Thank you, Yusuf, for your comment. Thank you very much. And thank you all for attending today. Yeah.